Greetings everyone, today I would like to discuss on secondary prevention of arthropod-borne infections. Dengue is the most common mosquito-borne disease in Malaysia, so I will discuss on this disease in details. Like other arthropod-borne diseases, dengue virus infection produces a broad spectrum of symptoms, many of which are non-specific. Thus, a diagnosis based only on clinical symptoms is unreliable. Early laboratory confirmation of clinical diagnosis may be valuable, because some patients progress over a short period from mild to severe disease and sometimes to death. Early intervention may be life-saving. In order to prevent dengue infection, first of all we need to know how to diagnose a dengue infection. This can be done by the dengue diagnostic tests, which include the serology tests, the virus culture and the polymerase chain reaction. The table shows interpretation of dengue diagnostic tests, adapted from dengue and control study. Unfortunately, an ideal diagnostic test that permits early and rapid diagnosis, is affordable for different health systems, is easy to perform, and has a robust performance, is not yet available. Dengue fever can easily be confused with non-dengue illnesses, particularly in non-epidemic situations. Depending on the geographical origin of the patient, other etiologies, which include non-dengue flavivirus infections, should be ruled out. These include the yellow fever, Japanese encephalitis, St. Louis encephalitis, Zika, and West Nile. Other different diagnoses include the alphaviruses, such as henbis and chikungunya, and other causes of fever such as malaria, leptospirosis, typhoid, rickettsial diseases, measles, enteroviruses, influenza and influenza-like illnesses, and also hemorrhagic fevers. During dengue outbreak, some patients may be seen presenting with fever with or without rash during the acute illness stage. Some others may present with signs of plasma leakage or shock, and others with signs of hemorrhages, while still others may be observed during the convalescent phase. One of the priorities in a suspected outbreak is to identify the causative agent so that appropriate public health measures can be taken, and physicians can be encouraged to initiate appropriate acute illness management. In such cases, the rapidity and specificity of diagnostic tests is more important than test sensitivity. Samples collected from febrile patients could be tested by nucleic acid methods in a well-equipped laboratory or a broader spectrum of laboratories using an ELISA-based dengue antigen detection kit. If specimens are collected after day 5 of illness, commercial IgM ELISA or sensitive dengue IgM rapid tests may suggest a dengue outbreak, but results are preferably confirmed with reliable serological tests performed in a reference laboratory with broad arbovirus diagnostic capability. Serological assays may be used to determine the extent of outbreaks. Surveillance is important in controlling dengue. The objectives of public health surveillance which are most applicable to dengue are as follows: detect epidemics quickly for early intervention, measure the burden of disease, and provide data for the assessment of the social and economic impact of dengue on the affected community, monitor trends in the distribution and spread of dengue over time and geographically, evaluate the effectiveness of dengue prevention and control programs, and also, facilitate planning and resource allocation on the basis of lessons learned from program evaluation. To control dengue effectively, early warning systems are essential, which include event-based surveillance, case-based reporting of human disease or aggregated data reporting, and surveillance of risk factors for human disease. Event-based surveillance is designed to rapidly detect unusual or unexpected disease events such as disease clusters, for example unexplained fever or acute hemorrhagic fever syndrome, and unexplained deaths. It may include events related to potential exposure for humans, such as climatic conditions favorable to oviposition and subsequent maturation of mosquitoes. This surveillance uses reports generated by the media and other open sources of information, or via key informants in the affected community, as well as reports provided through established surveillance systems. Unlike classical surveillance systems, it uses unstructured and ad hoc reporting of events rather than the routine collection of data and automated thresholds for action. To be effective, it requires that a public health unit or team is designated to sort incoming information, confirm each reported event, and trigger an immediate response, as appropriate. The utility of traditional dengue surveillance in triggering rapid response is strengthened by the availability and real-time collection, analysis and interpretation of linked clinical, laboratory and epidemiological data using established case definitions of infection and disease. The threshold for alert and response will vary according to the operational level affected, that is local, national, and international level, and whether the affected area is endemic for dengue or at risk of its introduction. For example, at the local level a single dengue case may trigger action. At state or provincial level, the increase in reported cases above an established baseline for the same week or month in preceding years, or increasing vector density, may indicate impending epidemic activity. At national level, the detection of changes in virus serotype, subtype or genotype distribution, clinical severity or seropositivity rate, or the introduction of a dengue vector into a new ecological niche, are signals that should be investigated without delay. Well-defined triggers should be identified and established before the emergency occurs, in order to intensify surveillance and follow-up, and to initiate the emergency response. The following indicators are used for epidemic detection, which include excess of dengue cases, virus isolation rate in excess of routine virological testing rate, appearance of new dengue serotype, fever alert, in excess of non-malaria fever cases in malaria endemic areas. The routine reporting of dengue cases or dengue-like syndromes can use passive, active or enhanced surveillance. Passive surveillance is the routine reporting of diseases, by which notification is usually initiated by healthcare providers. A particular challenge of passive surveillance systems is continuously to motivate healthcare providers to report cases in accordance with standardized case definitions. Unfortunately, in many dengue endemic countries, surveillance is only passive and relies on reports by local physicians, who may not consider dengue in their differential diagnosis, and/or fail to report cases quickly and routinely. As a result, an epidemic has often reached, or passed its peak before it is recognized, and opportunities for control are missed. Designating dengue as a notifiable disease that is covered by public health legislation is one way to increase compliance with reporting. In active surveillance, the disease report is initiated by the health authority, which systematically asks healthcare providers about the disease of interest. This involves outreach by public health authorities to stimulate reporting. Examples include regular telephone calls or visits to laboratories and hospitals to collect data in a timely fashion. Sentinel surveillance, or the study of disease rates in a specific cohort, geographic area or population subgroup, is a form of active surveillance that is useful for answering specific epidemiological questions. It may be very effective at determining disease trends locally, but because sentinel sites may not represent the general population or the general incidence of dengue, they may have limited value in determining national disease patterns and trends. Sentinel surveillance may also be used to detect a first case, such as testing for dengue in a neurology ward, to detect cases of dengue-related neurological disease, or post-mortem testing for dengue-related deaths. Enhanced surveillance is a form of active surveillance usually in response to an epidemic alert. The passive surveillance system is enhanced so that it becomes active during the alert period, and/or it is extended to municipalities or jurisdictions that are beyond the affected area, and that would not normally be included in routine surveillance. Laboratory support provides early warning of impending epidemic transmission. It should include both serological and virological diagnosis. Quality control for laboratory diagnostics should be provided by a national dengue reference laboratory and/or an international reference laboratory. At a minimum, diagnostic laboratories should be capable of performing IgM antibody capture ELISA as a frontline screening test for current or recent dengue infection. Confirmatory tests are needed to exclude cross-reactivity with other flaviviruses, because IgM will not be detectable in the first few days after onset of illness, especially in primary dengue infections, and may persist for several weeks after infection. Data that are not linked to clinical and epidemiological information must be interpreted with caution. Examples are participating laboratory identifier, onset of illness, specimen collection date, patient identifier, organism, patient sex, date of birth or age, place of residence, specimen source, clinical diagnosis and the method of diagnosis. The ability of laboratory tests to distinguish acute infection from past infection without a clinical history must also be taken into account when interpreting the data. Although changes in incidence cannot be determined with precision from such data, general trends can be observed, such as seasonality and the age-sex distribution of dengue cases. The dengue emergency response is also important in managing dengue. There are two major components, which are the emergency vector control, to curtail transmission of the dengue virus as rapidly as possible, and the early diagnosis followed by appropriate clinical case management of severe dengue, to minimize the number of dengue-associated deaths. Dengue emergency response planning can be divided into three levels. The first is ongoing prevention, which is conducted although there is no current dengue activity in the area. The second level is the response to sporadic cases or other risk indicators, where there is no epidemic dengue activity in the area but either sporadic cases are being reported through the surveillance system, or there is increased virus activity or the introduction of serotypes that have not previously or recently been recorded in the area. The final level is the outbreak response, where there is epidemiological evidence of epidemic activity. The best response to a dengue epidemic is preparedness to prevent infections, thereby reducing ongoing transmission, and to minimize its effects on those who become ill. The priority areas for emergency response plans include establishing a multi-sectoral dengue action committee, formalizing an emergency action plan, enhancing disease surveillance, diagnostic laboratory testing, enhancing vector surveillance and control, protecting special populations, ensuring appropriate patient care, educating the community and relevant professional groups about the current procedures used for dengue control by the responsible authorities as well as their roles and responsibilities in dengue prevention and control, investigating the epidemic, managing the mass media. The emergency response plans are different in each country. For endemic countries, the plans are to reduce the risk of dengue epidemics, and to strengthen control measures for any future epidemics, thereby minimizing the clinical, social and economic impact of the disease. On the other hand, the receptive countries, which are the countries where the dengue vectors are present without circulating virus, the focus is on strategies for risk reduction. These should include rapid investigation of sporadic cases, to determine whether they are imported or locally acquired, monitoring of vectors and their abundance, social mobilization, and environmental management efforts. Once a locally acquired case is confirmed, the response may be escalated to epidemic response, to prevent further spread and/or interruption of transmission. In countries at risk of the introduction of dengue vectors, the focus of activities may be on epidemiological surveillance at ports of entry and education of the healthcare community about the risk of dengue in travelers, and its diagnosis and reporting requirements. The population at risk of being infected by dengue virus include the older or incapacitated persons, who live alone or in institutions, travelers, preschool children in daycare programs, students, migrant workers and soldiers. If not properly screened or air-conditioned, healthcare settings may also be at high risk for dengue transmission. The communication for behavioral impact for dengue prevention and control needs to be tailored to the various populations at risk, and delivered in a culturally appropriate way to ensure sustainability. A case of severe dengue requires careful observation and repeated laboratory tests throughout the illness. The principal burden due to dengue is not the number of deaths but the enormous number of hospitalizations and days of illness. To ensure appropriate patient care, the criteria for triage, trained physicians and nursing personnel, beds, supplies and equipment, and training guidelines for treatment and patient isolation are required. Epidemics of dengue are frequently marked by uncertainty, confusion and a sense of urgency. During an epidemic, the aim of public risk communication, generally through the media, is to build trust. It does this by announcing the epidemic early, providing accurate information, communicating openly and honestly with the public, and providing specific information about what people can do to make themselves and their communities safer. This gives people a sense of control over their own health and safety, which in turn allows them to react to the risk with more reasoned responses. In endemic countries, involving the media before the occurrence of the seasonal increase in dengue enhances the opportunity to increase public awareness of the disease and of the personal and community actions that can be taken to mitigate the risk. Another area for an emergency response plan is to provide information about an impending increase in the incidence of dengue, which will then provide valuable time to make final preparations and implement the contingency plan. In areas where a comprehensive surveillance system exists, detailed information about when and where dengue outbreaks or epidemics occurred in the past can be a useful guide to the potential magnitude and severity of future epidemics. If there is no surveillance system in place, the early warning element of the program and the valuable time needed to make preparations for the response are lost. In such a situation, the emergency may rapidly overwhelm the public health and medical care agencies without warning. In addition to human resource planning for surge situations such as epidemics, the education of healthcare workers should draw attention to the importance of laboratory testing and case notification. Many healthcare providers fail to report dengue activity until they receive a positive laboratory diagnosis, because they are unaware that prompt vector control measures can be initiated as soon as suspected cases are notified. Some doctors may not request tests during an outbreak, because they may be confident of their ability to diagnose dengue clinically. Other doctors may not be aware of the value of laboratory confirmation, or may not be familiar with the tests available, the timing of investigations, and the problems inherent in interpreting laboratory results when more than one flavivirus is circulating, or the patient has been exposed to dengue or other flaviviruses in the past. Physicians, nurses and laboratory staff should receive regular clinical training in the management of dengue patients. This must include specific training on aspects of emergency response. Clinicians. Education in the emergency response to a dengue epidemic relates principally to raising awareness of the spectrum of disease and the essentials and complexities of treatment. It is important to emphasize that treatment of dengue consists of appropriate hydration and the administration of paracetamol or acetaminophen to control pain and fever, and not to use aspirin. Physicians must be able to distinguish between typical and atypical dengue syndromes, and access to laboratory diagnosis is useful. Contact should be made with national and regional reference laboratories for diagnostic support and verification functions prior to the occurrence of an epidemic. Epidemics also offer unique opportunities to identify risk factors for the disease through applied research. Clinicians are often the first point of contact for community education and social mobilization. Assessment of the surveillance system should be adapted to country needs and resources. Priority should be given to improving routine reporting using standardized case definitions, improving laboratory support for diagnosis through greater access to laboratory services, standardized test procedures, access to more sophisticated diagnostics for virus tracking and quality assurance, and introducing active surveillance as a complementary measure. At all times, appropriate and timely data analysis and response at the lowest operational level possible are crucial, as is data sharing in the system. This may mean that core capacities in surveillance and response need to be developed in accordance with the international health regulations. Reporting of dengue should be consistent both within and between countries, and reported cases should have a defined severity level. Once a vaccine becomes available, effective disease surveillance will be critical in determining priority areas for vaccine use, and evaluating vaccine effectiveness in reducing dengue incidence. Resource planning and assessment should include auditing of, for instance, the availability of diagnostic laboratories and staff trained in dengue diagnosis, verification and reference functions, reagents and laboratory equipment, which includes stockpiling for epidemics, quality assurance, and the continuous application of appropriate levels of biosafety. The capacity to perform dengue virus genotyping, whether locally or at an international dengue reference laboratory, is particularly important for tracking genetically the potential origins of outbreaks and the international spread of the virus. Hospital emergency response plans for dengue should include a detailed resource plan that covers anticipated hospital bed occupancy, including high-dependency care beds, staffing levels and surge capacity needs, and stock management, such as intravenous fluids and drug supplies. Similar assessments should be conducted for outpatient care in the public and private sectors in dengue endemic areas. The adequacy of equipment for insecticide application and the availability of insecticides should be part of the needs assessment of the vector program. Besides the mentioned areas in emergency response plans, investigation of post-mortem cases is also important. A repeat dengue serology should be obtained at the time of death. Suitable specimens for virus isolation and/or RT-PCR and/or antigen detection are recommended for confirmation of diagnosis. The management of dengue is mainly supportive care, which include fluid management and also bleeding management. For fluid management, individuals are encouraged to have adequate oral fluid intake. For fluid is indicated in patients who are vomiting or unable to tolerate oral fluids. For fluid is also indicated in patients with increasing HCT despite increased oral intake, which indicate ongoing plasma leakage. Crystalloid is the fluid of choice for non-shock patients, whereas colloids may be preferable as the fluid of choice in patients with intractable shock in the initial resuscitation. For the management of bleeding, transfusion of blood and blood components in dengue is indicated when there is evidence of significant bleeding. In Malaysia, there is a stepwise approach on outpatient management of dengue infection. First step includes overall assessments, which are history, examination and lab investigations, that is FBC, HCT, and dengue serology. The second step is to diagnose the disease along with staging and severity assessment. Final step is to notify the district health office via phone followed by disease notification form. If admission is indicated, the patient needs to be stabilized at primary care, and communication with the receiving hospital or emergency and trauma department need to be done before transfer. If admission is not indicated, daily or more frequent follow-up is necessary, especially from day 3 of illness onwards until the patient becomes febrile for at least 24 to 48 hours without antibiotics. There is no effective vaccine available for dengue. There are 3 tetravalent live attenuated vaccines, which are under development in Phase 2 and Phase 3 clinical trials, and 3 other vaccine candidates are at earlier stages of clinical development. In special situation, such as dengue in pregnancy, all pregnant women with suspected dengue infection must be admitted. The management is almost similar to that in non-pregnant individuals. Care for the mother should be provided in a multidisciplinary way in an area of the hospital, where there are trained personnel available to handle labor and its complications. If possible, avoid lower segment cesarean section or induction of labor during critical phase. The baby should be observed for vertical transmission of dengue after delivery. The next mosquito-borne disease, which will be discussed here, is malaria. The diagnosis is with a thick blood smear to detect the parasites, and a thin smear to determine the species. A dipstick method for P. falciparum has made the diagnosis of malaria simpler, but is still too expensive for routine use in many countries. It is particularly useful for surveys. A similar dipstick method for the other malaria parasites has been developed, but is not sufficiently sensitive or specific to replace blood slides. The parasite life cycle can be represented mathematically. The stages and values for each of the places where the life cycle can be interrupted are given. In human, reduction of the duration of infection can be done by chemotherapy. The prevention of infections with gametocytes can be done by chemoprophylaxis and vaccination. Prevention of human biting can be done by personal protection and mosquito nets. In order to decrease mosquito density, larviciding and biological control are required. For the reduction of the proportion surviving to infectivity, this can be done by residual insecticides and treated mosquito nets. Reduction of the mosquito expectation of life can be established by knockdown in residual insecticides. This is the mathematical model of malaria based on the schematic life cycle of the parasite. The stages and values for each of the places where the life cycle can be interrupted are described in previous slide. For treatment of malaria, chloroquine is used for an uncomplicated case of P. vivax, P. malariae and P. ovale malaria. P. falciparum is resistant to chloroquine and many other anti-malarial drugs, so individual countries will have their own treatment schedules depending on the resistance pattern and the drugs available. Quinine, fluquine, artemether, arsenate, artemethyl, chlorproganildapsan and artemisinin-based combination therapies, such as artemether with lumefantrine, are available. Arsenate in single-dose rectal suppositories is a new approach to treating malaria in children who are not able to take medicines orally. In P. vivax, chloroquine will only clear parasites from the blood, and to effect radical cure, primaquine is administered. The third mosquito-borne disease that will be discussed here is lymphatic filariasis. Diagnosis used to be by finding microfilariae in a measured sample of blood using a thick blood smear, counting chamber or filtration technique, taken during the peak microfilarial output, which generally means collecting samples at night time. These laborious methods have now largely been replaced by circulating filarial antigen detection either based on ELISA or an immunochromatograph IC card. However, the card test only diagnoses positive or negative, while the ELISA is semi-quantitative, so where full quantitative measures are required, measured blood sample methods will still need to be used. To manage lymphatic filariasis, WHO provides strategy with two key components, which are stopping transmission through large-scale annual treatment of all eligible people in an area or region where infection is present, and also alleviating the suffering caused by lymphatic filariasis through increased morbidity management and disability prevention activities. For large-scale treatment, which is the preventive chemotherapy, a single dose of 2 medicines are given annually to an entire at-risk population in the following way: albendazole, 400 mg together with ivermectin, 150 to 200 mcg kilograms, or with diethylcarbamazine citrate, 6 mg kilograms. If this measure is conducted annually for 4 to 6 years, it can interrupt the transmission cycle. For morbidity management, it includes the treatment for episodes of adenolymphangitis. There is guidance in applying simple measures to manage lymphedema and hydrocele to prevent progression of lymphedema and debilitating, inflammatory episodes of adenolymphangitis. Hydrocele surgery is another morbidity management and treatment with antifilarial medicines to destroy any remaining worms and microfilariae by preventive chemotherapy or individual treatment is also required. Yellow fever is another mosquito-borne disease to be discussed here. The diagnosis is made on clinical grounds after initial identification of an outbreak. The virus can be isolated from the blood in specialist laboratories. Specific IgM in early sera or horizon T-trin-paired serum can be of value, but cross-reactions can occur with other flaviviruses. There is no specific treatment, but supportive therapy is given to combat shock and renal failure. One attack of yellow fever confers immunity for life, if the person survives the disease. This disease can be prevented by vaccination, which provides immunity for at least 10 years and probably longer. In the event of an epidemic, ring vaccination can be performed. The epidemic is surrounded by a circle of vaccinated persons, progressively closing in on the center of the outbreak. Areas of Africa and South America have been designated as yellow fever areas, and all visitors to this zone require vaccination. For Japanese encephalitis, another mosquito-borne disease, the diagnosis is by finding the specific IgM in cerebrospinal fluid or serum. The virus can be cultured in specialist laboratories. There is no antiviral treatment for patients with JE. Treatment is supportive to relieve symptoms and stabilize the patient. There are 4 main types of JE vaccines currently in use for prevention: the inactivated mouse brain-based vaccines, inactivated cell-based vaccines, live-attenuated vaccines, and live chimeric vaccines. The live attenuated SA14, 2 vaccine manufactured in China has become the most widely used vaccine in endemic countries, and it was pre-qualified by WHO in October 2013. Another arthropod-borne disease to be highlighted is onchocerciasis. The diagnosis is made by taking skin snips, which are placed in saline and the liberated microfilariae identified. Taking a measured area of skin with a special punch allows density measurements to be made. A slit lamp examination of the eye may reveal microfilariae in the anterior chamber or characteristic eye damage. The adult worms live in palpable nodules in the skin, so their presence and characteristic skin changes can suggest a clinical diagnosis. Treatment of this disease is by ivermectin for at least once yearly for about 10 to 15 years. There is no vaccine or medication to prevent infection with ovovirus. Prevention can be done by reducing the fly density, avoidance of fly breeding places, reducing the microfilarial density by ivermectin, reduction of the number of adult worms by nodulectomy, and reduction in the number of simulium bites. Lusis which caused by Lolo is diurnally periodic, and diagnosis is made by examining daytime blood, in which the microfilaria will be found. Mancinella ozardi, M. perstans and M. streptococcus are also commonly found in blood and skin smears in the same area and need to be differentiated from LO, as well as W. bancrofti and ovovirus. Both adults and microfilariae are killed by DEC, but caution needs to be exercised as allergic reactions can be profound. Steroid cover may be required in those with more than 30 microfilariae mm 3. Ivermectin will reduce the microfilarial stage and produces less reaction, so is more suitable for mass control programs. The main preventive action being against the bites of chrysops with protective clothing and repellents. Clearing the forest canopy, oiling of pools and mass treatment with ivermectin are essential too. In African trypanosomiasis, which is also known as sleeping sickness, the disease management is made in 3 steps. First is to screen for potential infection. This involves using serological tests, which is only available for TB gambines, and checking for clinical signs, especially swollen cervical lymph nodes. The second step is to diagnose by establishing whether the parasite is present in body fluids, and the final step is to stage the disease, to determine the state of disease progression. This entails examining the cerebrospinal fluid obtained by lumbar puncture. Diagnosis must be made as early as possible to avoid progressing to the neurological stage, in order to elude complicated and risky treatment procedures. In a sleeping sickness area, a surveillance service should be set up. Sleeping sickness workers are recruited more on their knowledge of the local community than their medical skills, as the simple techniques of gland puncture, or making a blood slide can easily be taught. The workers cover a set area, and take slides from people with symptoms of persistent fever and headache, or those who pursue a particular occupation, such as hunters, honey collectors or woodcutters. In TB gambines infection, palpation for neck glands can provide a useful estimate of prevalence. In an epidemic of TB rhodesians, a mass blood slide examination can be performed in the worst affected areas to detect asymptomatic cases. The illness in animals is more extensive than in the human population, and veterinary services often set up extensive surveillance and control programs, so combining efforts with them can be of value. Treatment of sleeping sickness is divided into 2 stages. The first stage, which is the hemolymphatic stage, uses 2 medications, which are pentamidine. It is used for the treatment of the first stage of TB gambines sleeping sickness, and suramin, which is used for the treatment of the first stage of TB rhodesians. In second stage treatment, melarsoprol is currently recommended as first-line treatment for the rhodesians form, and as second-line for the gambines form. Eflornithine is only effective against TB gambines. A combination treatment of nifurtimox and eflornithine is currently recommended as first-line treatment for the gambines form. Pentamidine has been used as a prophylactic against TB gambines to people at special risk. There is no prophylactic against TB rhodesians infection. Chagas disease, The American trypanosomiasis is diagnosed by finding the organism in the blood in the acute stage. Methods of concentrating the erythrocytes or xenodiagnoses, which is the feeding of laboratory-reared clean bugs on the patient, are often required. In the chronic case, serological tests may be positive. It is treated with benznidazole and also nifurtimox. Both medicines are almost 100% effective in curing the disease, if given soon after infection at the onset of the acute phase. However, the efficacy of both diminishes the longer a person has been infected. Benznidazole and nifurtimox should not be taken by pregnant women or by people with kidney or liver failure. Nifurtimox is also contraindicated for people with a background of neurological or psychiatric disorders. Additionally, specific treatment for cardiac or digestive manifestations may be required. There is no vaccine for Chagas disease. Blood screening is necessary to prevent infection through transfusion and organ transplantation. Depending on the geographical area, WHO recommends the following approaches to prevention and control: the spraying of houses and surrounding areas with residual insecticides, house improvements to prevent vector infestation, personal preventive measures such as nets, good hygiene practices in food preparation, transportation, storage and consumption, screening of blood donors, testing of organ, tissue or cell donors and receivers, and screening of newborns and other children of infected mothers, to provide early diagnosis and treatment. Leishmaniasis is a disease transmitted by the bite of infected female phlebotomine sandflies. The diagnosis is by the detection of the intracellular infected macrophages, which is known as the Leishman-Donovan bodies, and can be detected in liver, spleen, bone marrow or cutaneous lesions by stained smear or culture. PCR techniques can also be used. It is treated with sodium stibogluconate or meglumine antimonate, but pentamidine or amphotericin B may be required in cases that do not respond, especially mucocutaneous leishmaniasis. Because of the toxicity of the preparations, treatment should be undertaken in hospital. Outbreaks should be reported to neighboring countries, so that they can take control measures in border areas. Patients with HIV infection should be examined for reactivated leishmaniasis, so that they can take control measures in border areas. Patients with HIV infection should be examined for reactivated leishmaniasis. The next arthropod-borne disease to be discussed is plague. Plague is an infectious disease that is caused by the bacteria Yersinia pestis. To diagnose plague, fresh aspirate from a gland or sputum stained with gram stain will show the bipolar staining organism in preliminary field investigations. Culture onto blood agar or desoxycholate can be made from blood, throat swabs, sputa and material aspirated from buboes. Fluorescent antibody or antigen capture ELISA is a specific confirmatory test. Asymptomatic cases of plague are common during epidemics, and can be detected near foci by the passive hemagglutination test. For the treatment, streptomycin is the treatment of choice, but can cause a Hergeheimer reaction, so tetracycline is preferable in the critically ill. Doxycycline, chloramphenicol, gentamicin and cotrimoxazole have also been used. To manage plague outbreak, first of all find and stop the source of infection, that is to identify the most likely source of infection in the area where the human case was exposed, typically looking for clustered areas with large numbers of small animal deaths. Appropriate sanitation and control measures are required to stop the exposure source. It is also important to inform health workers as soon as possible and ensure correct treatment and that local supplies of antibiotics are adequate. Patients with pneumonic plague need to be isolated as they are very contagious. Health workers also must obtain specimens for laboratory confirmation. Surveillance of foci should be maintained with regular trapping of rodents, to examine them for infection and their flea populations. Notification of any confirmed or suspected case of plague must be made to WHO in neighboring countries. Any person traveling from an area where there have been cases of plague should be placed under surveillance for 6 days. Any cases dying of plague should be buried or burnt with aseptic precautions as well. There is vaccine available for plague. The vaccine will protect persons at risk for several months, but should not be relied upon. Chemoprophylaxis with tetracycline 250 mg 4 times a day or doxycycline 100 mg a day for a week should be given to close contacts of cases and medical workers at risk. For arthropod-borne disease like typhus, the diagnosis will probably be on clinical grounds, the eschar of scrub typhus being characteristic, but where available, the indirect fluorescence antibody test, labeled enzyme with LISA, latex agglutination or PCR can be used. Doxycycline, irrespective of age, is the treatment of choice. Alternatively, tetracycline may be given, and where both of these are unavailable, chloramphenicol may be used. Careful nursing is of utmost importance. Surveillance is the cornerstone of prevention by conducting louse and ticks surveys at clinics, prisons, institutions and collections of people. Cases of proven or suspect epidemic louse-borne tick-borne typhus should be notified to WHO. All contacts of a case should be placed under surveillance for 14 days. Prophylactic antibiotics, generally tetracycline, can be given to contacts to reduce the extent of the reservoir. Treatment centers should be set up to discover cases early and antibiotics given. Vaccines have been successful in controlling epidemics, but they suffer from various disadvantages. A killed vaccine is painful when injected and does not give complete immunity, whereas a live, attenuated vaccine appears to give solid immunity for over 5 years, but must be prepared carefully as virulence can increase. Vaccines can either be used for mass administration in the face of epidemics, or be given to individuals at increased risk, such as medical personnel. In the case of louse-borne relapsing fever, the diagnosis is by dark field illumination of fresh or stained blood taken during a pyrexial episode. Treatment is with a single dose of procaine penicillin on the first day, followed by tetracycline 250 mg on the next day. For surveillance, the cases of louse-borne relapsing fever must be notified to and neighboring countries. Routine inspections for lice should be carried out where facilities permit, such as in prisons, institutions and to new arrivals coming into refugee camps. For tick-borne relapsing fever, the diagnosis is made by finding the spirochetes in the blood during febrile periods, when blood slides should be taken, and either stained or viewed by dark ground illumination. An improvement on this technique is the direct centrifugal method. Treatment for tick-borne relapsing fever is with a single dose of 300,000 units of procaine penicillin immediately, followed the next day by tetracycline 500 mg 4 times daily for 10 days. This regime provides adequate treatment, while at the same time minimizes reactions. During surveillance, mass screening using fresh or stained blood slides can be used to delineate the infected population prior to a control program. Meanwhile, Rocky Mountain spotted fever, the diagnosis is made clinically with the additional help of enzyme immunoassay and immunofluorescence tests containing the specific antigen. Treatment of Rocky Mountain spotted fever is with doxycycline, tetracycline or chloramphenicol. Regarding the surveillance, dogs and other animals should be checked regularly for ticks. In the case of Lyme disease, the diagnosis is mainly clinical, the erythema migrans lesion exceeding 5 cm, aided by serological tests, which are more useful in the later stages of the disease. Treatment is effective with doxycycline or amoxicillin in the early EM stage of the disease. In the late arthritic, cardiac or neurological stage of the disease, treatment is with benzylpenicillin or ceftriaxone for up to 21 days. A vaccine has been developed against Lyme disease in North America, but is not effective in other parts of the world. It is only useful for persons at constant risk of infection, such as game wardens or camp attendants, but other precautionary measures should also be taken.
Okay, so this I was talking about the secondary prevention of dengue. Okay, so is there any question on the floor?
Yeah, I have one question. What are the major difference between the dengue endemic countries and also the dengue respective countries?
Okay, when you say dengue endemic country, it means that both the vector and also the circulating virus is present in the area. whereas if you say it's a receptive country, right, you have the vector, but the circulating virus is not found in the vector. Yeah, difference.
Yeah, is there any specific treatment for dengue?
For dengue, mainly is for supportive treatment. There is no like specific treatment. We only emphasize on the hydration. We have to adequate hydration is important, and also we have to make sure patient has control of the fever and also pain management as well.
In the present day, are there any vaccines available for dengue?
Basically, there is no effective vaccine available yet. But there's a few vaccine is under the clinical trial, and another few is under the early stage of clinical development.
Alright.
Any other question?
Why aspirin is contraindicated in dengue?
Aspirin, because when you have dengue, your platelet count will be reduced, so it can cause your your body tends to bleed easily, and aspirin also serving the same purpose. So if you take aspirin when you have dengue, you will tend to lead the patient bleed more profusely and can lead to dengue shock syndrome.
Is there any specific management for the pregnancy for dengue?
Regarding this issue, management for pregnancy and non-pregnant individuals are the same. However, you have to keep in mind that when pregnant mother has in the critical phase, which is the plasma leakage phase, you cannot do the cesarean section, which is the operation, and also the induction of labor. And also after delivery, you should not should be monitor any like vertical transmission to the baby. Is there any other question?
I think we're good for now.
Okay, I think that's all. Thank you very much.